There we go. Continue, and I'll try to speak slow, a little bit less loud now too, and continue to work with them with the vaccination program, with the grant from ACOEM and CMSS to kind of, from a health and safety standpoint, which was kind of nice because I typically worked on the workers' comp side. And Denise is in charge of an interesting program at Albertsons where they're trying to address food safety and kind of working in terms of nutritional education and really reinforcing the importance of food as medicine. And so I think that, and it's great that, a company sees that as an opportunity and also sees it as an opportunity to kind of help. So this presentation is part of ACOEM's vaccine initiative. This is supported by the CDC, what's left of it, and as part of the U.S. Department of Health and Human Services, as part of a financial assistance award on the Council of Medical Specialty Societies, with 100% funded by the CDC. The contents of the authors do not necessarily represent the official views nor endorsement by CDC, HHS, or the U.S. government. That's their disclaimer. And the Specialty Societies Advancing Adult Immunizations, this is a collaboration with ACOEM, with the Council of Medical Specialty Societies and the CDC to improve quality initiatives surrounding vaccines. And the idea is education is paramount in terms of for individuals to embrace vaccinations. So how do we enhance vaccination rates? ACOEM and health systems are working to improve COVID-19, influenza, and routine adult immunizations among high-risk workers in an occupational health setting. So this is a very specific approach, and from what I can see, has been pretty effective in Albertson's situation. From an education and outreach perspective, we're trying to implement targeted education and disseminate information to raise awareness to encourage vaccinations, and also using data to improve vaccination programs. And this is part in terms of also intercommunication between state vaccine monitoring systems, so that so when people get vaccines one place, we actually know that they're if someone else wants to check, they're actually able to, which is kind of a big deal. For the CDC standards for adult immunization practice, the issues first to assess, recommend, administer, and document. So the issue first is to determine the immunization status of patients at every encounter, and then recommend the vaccines that they need, and recommend them to someone to give them the vaccine. And then the most important part also is documentation. And the QI initiatives look to focus on the CDC standards for adult immunization in particular. So what are the resources that are available? ACOEM has a vaccine resources hub. You can see there's a little plug there with the code. And there's also practical guidance for employer strategies to develop workplace vaccine initiatives. And there's also messaging that the CDC provides to help leverage trusted communication strategies to individuals to help foster vaccinations, and also expert insights. We can learn from partner presentations and best practices. And part of this collaboration has been different employers meet together, discuss what works, what doesn't work, and and from talking to Denise, it's been a very effective approach. So, what do we need to become? Vaccine champions. And one of the approach is CME credits. So there are educational modules out there for healthcare professionals. So that's actually kind of a huge incentive. Communications. How do you communicate? They could see I was cheating? Okay. So we want to, the SHARE method in terms of communicating information well so that the patient understands clearly about what you're talking about and the importance of what you're talking about, and then also make it easy to understand. And we have an online access system called the ACOEM Learning Management System. So what is Albertsons? Albertsons is over 2,000 retail stores, over 400 fuel stations, over 1,700 in-store pharmacies, 22 distribution centers, 19 manufacturing facilities, and they're in 34 states and the District of Columbia. And the biggest focus were urban areas and the distribution centers. I actually attended one of the fairs at the distribution center. And if you've never seen a grocery store distribution center, these are pretty amazing in terms of what it takes to get the foods into the trucks that deliver the food to your local grocery store. It's quite amazing in terms of what these individuals do. But it's also a very, it's a very, how do I put it? These individuals are, they're kind of like they're from Missouri, the Show Me State. They really want to be convinced and educated. Nothing's a freebie when it comes to when it comes to these kinds of initiatives. So Albertsons developed a phased-in approach which focused on major urban areas and higher-risk populations, and those tend to be more in the rural areas. And so in year one, they focused on work sites and primarily distribution centers. And these were areas where they identified where they had low vaccination rates, and they invited the surrounding retail stores and the office locations to participate. And these events were typically located in the distribution centers, so it took a little bit of effort for some of the retail people, but otherwise, the strategies included at these fairs basically educating people about awareness, making it fun, prizes. There was an on-site clinic typically present that served as a partner in the clinic, and the pharmacies, the local pharmacies sent pharmacy teams to administer the vaccines. And it was all very, if you've ever been to one of these types of fairs, it's very familial and it was kind of fun. It's fun. And there's a lot of, and all the vendors are giving out gadgets and gifts, so there's a good turnout. Year two, they continued with 2 distribution centers in the major urban areas and 1 corporate office location. And they tried a virtual learning module as well, and they also provided enhancements to the electronic health record to incorporate vaccine protocols and streamline documentation, and that was something that Denise really incorporated and did well from what I recall. And there were direct occupational health service clinics that were vendors and contracted, and they were also prioritized to emphasize vaccination to employees as part of their interactions, not just for work-related issues, but kind of incorporating that from a general wellness perspective. And also, there was a telephonic nurse that could be used to also provide education and become what they call a trusted voice. And that was kind of the key, is trying to develop that trust and the communication, so that individuals felt that they could communicate and be heard. And it's kind of one of the underlying themes, is that the employee can be heard, that if they have any hesitancy or concerns, they're heard. And in year 3, it's to continue in the same distribution centers and an additional distribution center. As you see, there was lots of them, and it was still included an on-site clinic, trusted voice, and collaborating with the pharmacy team to provide the vaccines as well as education. And these were typically done in health fairs, and you'd have COVID-19 offered. They expanded to tetanus, shingles, and pneumococcal vaccines. And more importantly, they also developed buy-in from the unions, and they were able to collaborate with the union and their benefits team, which really, I think, kind of helped expand the program from what I understand. So the key is they would focus on educational content on the intranet. They had a website called My ACI, and they expanded to trusted voice education, including local individuals that were taught and trying to develop champions, immunization champions. And so there's certain people that are very enthusiastic about it, And they also had an Ask an Expert educational video, so people would submit questions, and Denise typically would be up on the screen talking in the distribution centers on a screen, and she would be present, and a lot of people started to recognize her just from the videos, and they got buy-in from the DC manager, the general manager, and so they had these kind of going on all the time, so people learned by repetition, and I think that was kind of a key element of it. And those were the educational video loops. And they expanded the health fairs to incorporate vaccination, and they also, I think, collaborated with the American Heart Association, Red Cross, and other wellness components, including smoking, weight loss, and blood pressure, and trying to just foster general wellness in addition to the vaccinations. And they felt it was a huge success in 2024, particularly with partnering with the health and wellness from the union, because that establishes buy-in typically, and so, as most of us already know. So what were some of the challenges that were kind of experienced during this launch? Language barriers. And so that was something that took a little bit of effort to make sure that you had people that communicate more than one language. And it's not just the translation, it's the interpretation. And I think that was one of the key elements in terms of educating people, so that you have that cultural sensitivity so that people understand it. And in California, we had something called COVID-19 fatigue. There were a lot of compliance issues and masking requirements, et cetera, and things were not necessarily communicated as well as they could have been. And I think people didn't understand the importance of a lot of these issues, and it just kind of got lost. And I think that was part of the challenge in California, which is where I was working with them. And the other issues in terms of tracking and finding out people's past immunization history, and that's why the tracking component in terms of being able to communicate with the state databases was important. And also in terms of the education component, when more important during COVID-19, obviously, as we all experienced, there were different guidance in terms of how infectious COVID-19 is, how effective the vaccines were, et cetera. And there's so many competing sources of information, and that's where the trusted voice, kind of acknowledging all the differences, but at the same time reinforcing the importance of getting the vaccines that you need. And one of the things that were nice is that the company did pay for flu vaccines, but there was a little bit of issues in terms of which COVID vaccines were covered by the company, which ones were out of pocket. Typically at the fair they were included, so it didn't really matter, but that was a different issue. So these are some of the pictures from the health fairs. The lady with the firefighter is Peggy Lavelle, and Denise is in the middle, and she's on the side. It looks like actually at the Tracy, California Distribution Center, because I recognize the pharmacist administering the vaccine. So as you can see, it's kind of outdoors, good weather, and it looks like some of the vendors are setting up, but it's actually pretty fun. It's actually pretty fun. And so here are the immunization table that we're all kind of familiar with. And so this is some of the education we provide, available in English. There were OHNs available. There was a link to the IIS that I was talking about, so that way they could find out what their immunization status was. And if the vaccines weren't available at the health fair, they would refer to the local pharmacy at the store, and it would be coordinated so that they could expedite. And one of the kind of interesting things that we learned is in terms of what are some of the barriers, and why was there vaccine hesitancy with respect to COVID-19? And as you can see, the biggest ones are they don't trust the science, and they're unsure about side effects. And I kind of empathize with the brand new approach to vaccines, that what do we know and what don't we know. And one of my approaches in terms of dealing with that is there were millions of vaccines that were performed by the time a lot of people were getting them, and no one grew a sixth toe, no one had a third eyeball, and so we were all doing okay for the most part, and that kind of somewhat reassuring to most people. And just kind of asking them specifically about what were their concerns were. Most people don't have anything specific, and you just talk about what the risk benefits are in terms of, depending on your risk stratification, how bad is it to get this infection compared to the possible side effects that you've heard of that are non-distinct. And one of the other strategies that worked pretty well too is they also gave people grocery points. So that kind of overcame a lot of the barriers if you could get some kind of incentive to get groceries, et cetera, to the employees. That actually made a big difference. And the key points of this that I think the takeaways are the active listening component in terms of understanding, non-judgmental, and finding things to agree upon. And in medicine, I think that's it's easy for us to a certain extent because we're always skeptical in general of interventions, of anything new. And so we can empathize with them. It's just a matter of educating and translating our knowledge so that they can understand why it's better to get the vaccine or why it makes sense from a risk-benefit standpoint to do something that they're a little bit fearful of and what the benefit is. And so the idea was obviously empowering through education, helping them kind of make the decision to get vaccinated themselves as opposed to someone telling them to do it, making it more of an active decision on their part in terms of, yeah, that's the best thing I can do. It's kind of like choosing to buy the car that you want and not having it sold to you. And then kind of leveraging the storytelling component in terms of personal experiences. And so one of the strategies that they used was trying to find a kernel of truth in the information that people would say in terms of, I don't want to get a vaccine because I heard X or I heard Y. And you could say, well, I understand why you're concerned about X, I understand why you're concerned about Y, and that makes sense, but also, have you heard about this? Are you concerned about what would happen if you're diabetic and you get infected with COVID and you have to go to the hospital and what happened? So I think there's trying to get them to agree and understand was one of the key education components. So the take-home points to address vaccine hesitancy were to, one, listen, ask, and share. And so be non-judgmental, understand why they're concerned, acknowledge, and then understand what they're specifically worried about. Ask them where they're getting their information from, and then try to give them answers and answer their questions from an educated standpoint. And then also redirect them to sources that reinforce what you've already said, like the CDC or local health department website, so that they can investigate for themselves. And I think that was kind of the take-home points. I'm done. Thanks.
I'm going to take this off because it's jingled in the past on me. Oh, there we go. So I'm Dr. Karen Lennick. I'm a Director of Corporate Occupational Medicine at 3M. I've presented 2 years and, well, 3 years now in a row on this grant. So some of you may have been at prior sessions, so trying to take a new approach this year. Just so you know, I work at 3M and I have stock in 3M and Solventum. There's nothing in this presentation that has anything to do with 3M or Solventum products. So, and then I'll just show the same statement that Dr. Doss just showed about the funding coming from the CDC and HHS. So our quality improvement objectives were to establish a connection between our electronic medical record, or EMR, and our key state immunization information systems, reduce vaccine hesitancy, and increase vaccination rates for COVID and influenza among our 3M workforce at our 4 pilot sites, and expand work across the organization to increase knowledge and uptake of vaccines based on employees' age and health risks. So I'll start with the connection to the IIS. So our current state, being occupational health providers, so we have site nurses at our plants and distribution centers throughout the world, but in the U.S., they directly report in to corporate occupational medicine. So we're able to provide that guidance to them, and we also have a full-service clinic at the 3M Center Clinic in Maplewood, where we do executive health physicals, travel clinic, and urgent care. So right now, if a vaccine is given by a community provider and entered into the state IIS, it's not visible in our EMR. So it limits the ability of our nurses and doctors to efficiently assess and recommend vaccines, which is a key part, right, from the CDC. And then vaccines that are given internally are documented into our EMR, and then they must be manually entered into each state IIS separately, limiting information shared with the community providers due to time constraints. So during COVID, if we administered COVID vaccines, part of the agreement was you must enter them into the IIS, which I'm sure you're familiar with, and that was difficult to maintain. So some of our champions, like Lydine, who will talk after me, a nurse at 3M Austin, has continued that process and done a wonderful job. So our goal was to try to establish this electronic feed and, bi-directional. And there's different challenges to both, but less challenges to send your data to the IIS. It's a pretty, it's a fairly straightforward process. Of course, there's still the technological piece, but it is, if you get your account, even without computers, you can log into your individual employee's chart after you've given a vaccine and enter it into IIS. To receive the data, there's like an intermediary step 2, where you have to see that person asked to upload and update the information into the chart. So it's kind of a 2-step process. So while the information is there in the IIS, you can't just actively receive it. And there's different considerations. So being an employer versus part of a healthcare group. And prior to working at 3M, I was at a practice at a nonprofit, healthcare organization, where because ACOEM was within that larger group, I took it for granted how wonderful Epic and the connection was to our state registries. And that was only 2 states, whereas we're present in many states. So you have to take into account your legal, security, technology, and cost concerns. So I'm going to give an example for Minnesota. And Minnesota has the MIC, or the Minnesota Immunization Information Coalition. So there's laws stating a patient is anyone who has received healthcare services, a provider is any person or facility that provides services. So we've had this evaluated before, and our nurses, mid-level providers, and doctors are all considered a provider. Doesn't matter that we work for 3M, we're still healthcare providers in that capacity when we're seeing a patient one-on-one. And providers may exchange immunization data with one another without the patient's consent if the person requesting access provides services on behalf of the patient. So, you have to offer hepatitis B for your first responders. So, and yes, the employer pays for that vaccine, but if you provide the vaccine, they've consented to receive the vaccine from you, so you would have by law the right to enter that information into the state IIS. And that includes all immunization data, regardless of when the immunization occurred. So if you retrospectively, you finally get this set up, now you're online, by Minnesota law, you can now transmit that information, your historical data. And then for adults, MIC requires implicit consent with an opt-out by operational policy. So there's the law, and then there's your internal legal team. So our internal legal team, when they review this, the agreement, right, is that we're acting as a provider, giving that vaccination on behalf of them. But there is still some additional concerns, right? When did the sign, so we have a sign that keeps us in compliant with the MIC user agreement that we use MIC, and you can choose to opt out. Well, would it be okay to submit data that was given before that sign was posted? Would it be okay to submit the data between the time the sign was posted, now the sign's been posted, and today when you establish the relationship. So it's always important to take into account the internal legal decisions as well on how you can proceed with that data transfer. And then, of course, there's the data security issues. So, you have to bring all those stakeholders to the table and look at risk to your company. So how do you maintain that personal health information that you've been tasked with keeping safe? And then your threat and vulnerability review. So is it an acceptable risk in order to provide this service as a healthcare provider? And there's just so many more aspects to the company than just occupational medicine. So they're taking into account various pieces to that puzzle. And then technology and cost kind of come hand in hand. So I'm not aware of any state that would charge you any kind of cost for linking to their IIS. They have federal and state funding to bring people on board, but you do have to understand their requirements for data security, what your EMR has to be able to do in order to establish that link. And then you really have to understand the capabilities of your own electronic medical record system. So some are more advanced than others. Most will have an HLA-7 messaging system, and that's how they transmit back and forth information to laboratories. So you have to know if it can send and receive data. And again, it seems that sending is usually the easier, the more straightforward process than the receiving of the data. And you need an interface. So application programming interface, or an API, connects and sends that data. There is a cost associated with that, but usually that's a one-time cost. So, or there is a free option from the CDC, and it's the IZ directory, or the immunization directory. And it's a public option. It can take care of that interface connection, and it does not store the information. It just transfers it back and forth. So then you also need support. So you need internal resources to establish the connection and maintain the connection. So even if you hire a contractor, to get that connection going, your internal IT team will also need to be on board and take care of certain aspects. So there is a time and money component there as well. So our plan, our nurses and our providers utilize IIS at patient encounters when indicated. Again, they have to review their state IIS and make sure they have a sign posted that they're using this. All of our pilot sites do this, and several of our other plants do as well. And our plan was to start with an electronic push to MIC. We looked at other states where we could also utilize. The majority of our vaccinations are given in Minnesota. So we have historical data for hepatitis B vaccinations, Tdap. The COVID ones are already in. We've got flu data. We've been doing on-site flu clinics for years. But we also will have MMRs or typhoid for our travel health clinics. So there's a treasure trove of information. And then we also have the ongoing vaccines that we're doing every year. So we want to push those in to MIC. And get that data out to the providers, especially for things like hepatitis B, where now it's recommended for everybody under the age of 60, and we were before only giving it out if you had occupational risk. So that would save the community providers time to know that their patient already completed that series. And then we really want to work on the pull, but that's an exploration still. So it has a lot of more complexity to it on bringing the data in. Our EMR has not done that before. They've only recently started doing the push, and they've not actually completed a pull yet. And that's kind of an interesting interface, how do you interact? Because the whole idea here was to stop having two records to look at, not have to pull up MIC and look at that report, and then look in our EMR as to what we have given. So the goal is to have all the data in one place. And then also looking at expanding to other states as time and cost permits. So in South Carolina, for instance, it's a requirement that any vaccine you give, even at the workplace, is entered into Simon. So you have to look at your volume, right? So if you're administering 2,000 vaccines a year, you really need that electronic connection. If you're administering 50 a year, it is feasible for that site nurse to enter the data, even though it does take longer. I'd also argue that the data is more accurate, less prone to error, better security by using the electronic connection, because every time you pull up the patient's name, you have to make sure you pull in the right name, date of birth, and it's amazing. Didn't think it was possible, but there are very common names, and you might actually get an overlapping birth date. when you're looking at the data from a statewide, process. So it's really important to take that into account. And then also, if you're located in more than one state, you have to think about, they don't all talk to each other. So you have to figure out what is the priority of which state you want to connect to, having the best, the greatest overall effect for the money you're spending. And then prospective data transfer is definitely the easiest solution, but you can look at that historical data transfer. Because if you want all the data in one place, you want everything in one source or the other or in both. You don't want to have to keep looking at two reports. So then I'm just going to go into our pilot study. So I've presented on this the last 2 years, and I realize not everybody was at that presentation, but I'm going to kind of do an overview. So basically we ran the similar intervention 2 years in a row, new population each time. We obtained 3M IRB approval. We would recruit in the summers, and then we would obtain informed consent, and the baseline survey was completed in September. And then we offered education options, which we'll talk about in a minute, throughout the fall, and then the post-intervention survey would be sent out in January, completed by the end of February, and then we would analyze data. So as you can tell, not a lot of time to analyze data, so bear with me. So our pre- and post-intervention survey, we asked demographic information at baseline, and then we asked for health characteristics in more detail at baseline, but then any changes at the follow-up survey. Their vaccine beliefs, so we used the adult vaccination hesitancy scale by ACOEM. We also added some additional questions to that as well, and that's on a Likert scale, so from strongly disagree to strongly agree. We looked at vaccination status for COVID, flu, and tetanus, and reasons for not receiving COVID and influenza vaccines, which was added in the second round. So our vaccine education options were an online module, very convenient. There is a question at the end they have to answer, but it is prone to some people going through it a little more quickly than others, like any online training module. It was very easy to access for the manufacturing sites, so that was their preferred method because they do all of their training through the same system. It went through, reasons for adults to get vaccinated, side effects, potential side effects of vaccination, so what to expect on the day of the vaccination and the couple days following. The routine vaccinations for all adults should get, COVID, flu, and tetanus, and then other vaccines that you might be eligible for based on your age and health conditions. They go through and do the adult vaccination quiz, which is a great resource if you haven't seen it, and that's where you plug in different risk factors, and then it comes out and tells you what vaccines are recommended for you. It also went through how to find your vaccination records, which Clydine lovingly said, ask your mama. In the module, it just says ask your parents. But so trying to find that, your old immunization book, if anybody here is my age or older, we probably still had the little books. If you're maybe 10 years younger, it probably all went into your IIS and you never had to live in that world. But those little booklets are really helpful because for some vaccines, as you know, you only need them once. You need the series once and you're done. So, and then there's others where you need boosters. So trying to have them think through where they can find their records, introducing the concept of IIS to them. We have the main ones for where our pilot sites were located in Minnesota, Texas, and South Carolina, so there was a link there. If you did the Lunch and Learn, you also got a tutorial, which was really nice, hands-on, smaller group learning, very positively received, but very challenging to do. We were not able to find a way to do that at the manufacturing sites. So it was very well received and really liked at our office and research and development sites. And then finally, your how to get vaccinated. So your plan on how to get vaccinated and links for where you could go to do that. And then you could choose the one-on-one option, which we didn't have a lot of people, but everyone who did do the nurse consult, one-on-one consult, found it extremely rewarding, very helpful, and you could really do the full thing. You could assess, you could recommend. There are some vaccines we could administer depending on the site and what we offer. We don't process health insurance, so anything that's super expensive, we always have to refer off-site. And then document. And the site nurses would then document it in our EMR and also into the state IIS. So we had invited about 1,500 employees over both of those courses of the intervention, 2 plants, one in Minnesota, one in South Carolina, and 2 office and R&D sites, one in Minnesota and one here in Texas, at 3M Austin. And we had 215 employees that completed the informed consent and the baseline survey, and 190 that completed the vaccine education and post-intervention survey. After they completed that, they received a very nice 3M soft shell cooler, igloo cooler. So we had people who did a second round at Austin because they liked the cooler. I mean, swag, man, that's the way to go. So Claudine did a great job. She's got a great relationship with her workers too. So this is just the overall demographics. Our average age was about 47 to 48. So I like to look at that. 50 as a cutoff just because of vaccine recommendations changing, to shingles and now pneumococcal at age 50. So, pretty much, just slightly more than half were under 50. And we had a lot of male participants, which is great. I mean, most health education initiatives, you tend to see more women signing up. The primary race and ethnicity was non-Hispanic white. But we did get representation from other groups as well. Most people were married. We were kind of trying to look at whether or not there was that social considerations, right, for your family members and protection, so maybe trying to look at more of those connections. Highest education level, very educated group, especially at our office and R&D sites, where over 50% had a bachelor's, master's, or doctoral degree. But we did get folks, we had about 20% with a high school or diploma or GED, and another 20% with a technical certificate or associate's degree, so fairly well distributed for education. And then this is kind of interesting. So at our work sites, 56% were from manufacturing, but you could classify your job title as production or non-production. So we got a lot of non-production people at the manufacturing site, so we still ended up, we were hoping for, more of the production folks to really get to that demographic. And we still did pretty well with 63, but you can see how it kind of got lopsided. And so for work setting, so for primarily people worked on site, some hybrid, and some remote. So health risks of participants, which really drives what vaccine recommendations you would make. High degree of first responders, not surprising because in our second round, we also kind of did a subgroup where we worked with ERTs because our idea was to do vaccine champions in our next year, which CDC has since created, so we will offer those modules to the ERT and our healthy living teams so they can become vaccine champions and already know this basic knowledge as well. But also our sites have a very large, robust volunteer program. So most common health conditions were diabetes, asthma, COPD. Only, 11 or 7% still vape or smoke, so that's great. 6% reported being immunocompromised. And another 2% had a close contact of an immunocompromised person. Okay, this is kind of a hard slide to see. So we asked about concerns about vaccines, and most of them are, typical things that happen within, the day of or within a day or two of the vaccine, fever, chills, pain. But then we had 9 people who reported concerns about unknown long-term effects. Somebody reporting a concern about longer-term genetic impacts, death. So there's still, even in a group where you'll see was still fairly vaccine accepting, there are still these concerns that would not have, I think, seen pre-COVID. I don't think a lot of people were worried about long-term health effects from vaccines, or death from vaccines pre-COVID. On the vaccine belief scale, again, our population started off, fairly vaccine accepting. So with, 1 being strongly disagree and 5 being strongly agree on this Likert scale. So, being at 4s and 1 3.7 on average, you're shifted towards more likely to receive that vaccine. We did break this down by production and non-production, and there's, not surprisingly, a slightly higher start for the non-production folks. But in both groups, no matter what, we did see a small but statistically significant change in the positive direction towards being a little more accepting of vaccines. And that was regarding especially, vaccines that are important for my health, for family members, for coworkers, and community. then the next group of questions, looking at the CDC. So are vaccines recommended by the CDC beneficial? So you can see we start a little lower there to 3.6 versus in the 4s. And we had a little bit of movement, statistically significant but small. So trying to move people in the right direction. The nurse, trusting in the nurse, started really high and it moved up. It just didn't quite get significant, but they are very significant. So, and then there were some negatively worded questions on that scale. So you have to kind of, if you look at it where you'd want them to start low and you'd want to see it, the value go down further. So it did move in that direction. The I do not need vaccines for diseases that are not common anymore moved and was statistically significant, which is great with things like measles on the rise. So maybe it is more common now, so maybe that's why. But we still didn't make any difference on serious adverse effects or new vaccines carry more risk than older vaccines. So kind of started neutral, didn't really move much, and it wasn't statistically significant. And I mean, new vaccines, I understand just because you're concerned about newer vaccines doesn't mean you won't get the vaccine. And then we just kind of looked at it overall, like the pre and post survey, like the counts by category. So again, we're starting off fairly high with agree, and was the most common response for those 14 questions. And then at the end, strongly agree was the most frequently reported question. And that was after we reversed those 3 questions so that strongly agree was always high vaccine acceptance to keep them in the same order. So that's, it was a small but significant change. So our additional quality improvement efforts and next steps. So this is the handout we developed and very proud of. And it's been a really helpful educational tool. So there was something on the CDC website at the time, but it was not as up to date as we wanted it to be. So we worked on that to get it up. And now, we were coming out of we were still in like COVID era, and kind of coming a little bit out of COVID era when we started this. So we incorporated this, and what we did was take that first page. So the first page was great for counseling for what most of our population would need, and including that Hep B there as an important component. And then we went, to the second page if there was time to recommend additional vaccines. And one of the changes that was recently made is pneumococcal being moved from age 65 and older to 50 and older. So that's also now an important component, whereas before shingles was really the one we were trying to really get information out on. So we now have, we've always reviewed vaccination records when we were at 3M Center Clinic for executive physicals, but now there's a designated person who reviews them and fills out the handout, and we can hand that to the executives with vaccine recommendations. We have a fairly robust executive health program, so I don't know the exact number, but it is very large. It's not just like senior VPs or executive VPs, it goes down to like a director level. So it's a pretty broad group of who we see. And we've seen a lot of positives with that. So I'm, of course, a huge vaccine champion. So I can actually go into the IIS, and see their vaccination rates. And because now they've become my patient, I can see if they've gotten their vaccines. So it's very encouraging to see that pre and post versus for the intervention, it was all self-report. So you have to take it with a grain of salt. Did they really get the vaccine? Were they just telling us they got it? Were they afraid to report it? And they did actually get it. So it's hard to say with the self-reported. It's really nice when you can actually see a result from your counseling. Pilot sites are manually entering vaccines provided into their state IIS. A few other places are as well, but we want to really expand that. And then our pilot site at Austin held COVID clinics even after vaccines were no longer free through a community partnership. And we created message board templates regarding measles and pertussis. So we've always kind of focused on flu and cold season and get those shots. And we've kind of expanded out now to say, there's a measles outbreak, check on your immunity. This is the recommendations for MMR, for pertussis, get your Tdap, and Clydine will share that. People are coming and asking questions and saying, hey, can you look at my record and let me know if I'm up to date? So again, we want to expand, look at, we're going to survey our site nurses to see how many are familiar with their IIS. If they gave COVID shots, they should already have been registered, but some people use contractors, so they would never have been the one entering the data in. And then look at the feasibility of starting that process moving forward in a manual process, since even with an electronic connection, we could never connect all states. And then making sure all the nurses feel comfortable with doing a vaccine education consult, completing that handout if requested by an employee. That one-on-one counseling is so important. You can only get so far, but you really have to sit down and talk to that person to really make a difference. And then offering the online module across the organization, and getting credit for it through our Healthy Living Points, which would be your health promotion, discounted points towards your premiums. People like to do things for points. They like the coolers, but they like saving money on their health insurance premiums even more. And our new vendor is so great. They've already added different vaccines on. We're going to look through the whole list to make sure we've got all the pertinent vaccines listed as ways to get points for having completed those, and just continue moving our efforts forward. So the goal was always for this to be incorporated into what we do and not always be reliant on grant funds. And with that, I want to give Claudine some time to talk because I took too long. You're all set.
Good morning. Thank you for coming. We appreciate it. I'm Claudine Coy. I'm an occupational health nurse. I've been a nurse as long as I've been an occupational health nurse, so over 30 years. I graduated from the University of Texas, and my clinic is here in Austin, Texas. I'm a 3M employee, and I own stock in 3M and Solventum, which is a spin-off company of 3M. I have two buildings that comprise my site. One is a business, which is customer service. It's my clinic. Security is there. It's just an employee based. And the one up on the hill is a science building, and that's where all the laboratories are. And believe it or not, we can create lightning bolts in that building. And we do that to test products to see if they can withstand the being struck by lightning, I guess. It's for electronic material systems and electrical markets. The main division that I support is EMD. I support 340 on-site and remote employees. I'm seeing more remote come back. It's about a Tuesday, Wednesday, Thursday, so I do all my healthy living events on Tuesdays because I get the most participation. But we do offer them virtually too. I do all the influenza, and as of this initiative, I now enter them all in M-TRAC. It's a walk-in clinic. I administered 58 doses last year. I offer it to employees and family members greater than 18 years old. I enter, like I said, into M-TRAC. I enter into our EMR system. It's known as Cordy. I have a sign posted in the clinic that informs employees that that data is entered in M-TRAC, and they're given an opportunity to decline that. I don't accept any insurance. I'm paid by 3M, and I offer all kinds of services. I do medical emergencies, first aid, medical surveillance. I can do it all. And of course, 3M pays for the vaccine every year. I did on-site COVID clinics. I partnered with an incredible pharmacist out of San Antonio. They were a little pharmacy, and so we have a relationship and a collaboration and a partnership, and it has been just totally awesome. In fact, I hope this year I can offer more vaccinations other than just COVID. I hope that I can offer shingles, pneumonia. The pharmacist administered 31 doses. It went to employees only. She entered all the data into M-TRAC, which was like a blessing to me. I entered them all in our EMR. We had the sign posted for M-TRAC. She accepted personal medical insurance, so she filed all the claims for the medical insurance, and she also obtained all the consents online. So really all I had to do was show up, and make sure that the employees showed up for their appointments. And then she charged administration fee back to the insurance to vaccinate the employees. The feedback that we got for the on-site vaccine clinics, they prefer the convenience of on-site. They would prefer getting it there from somebody that they know, and also they don't have to leave work. I have a very trusting relationship with them. I've been there a long time. They know that they can trust me. They know that what they tell me is confidential and I won't share it. They had no complaints of returning twice for vaccinations, so what she offered was the Moderna. So they would get one shot and then they would come back for the second shot. And why we did that is that we would want to differentiate which vaccine caused those side effects, because we had some employees take Johnson & Johnson, and so they came to her to get the Moderna, so we had a lot of collaboration on that. And they do want more vaccines administered on site, so I'm going to send out a survey and see what their interest is. For me, it was a great experience. Minimal time, maximal benefit to employees. I'm fortunate to have a willing partner who accepts, the health information and protects it. Consider coordinating administration, of course, of additional vaccines, and like I shared, I'll plan to send a survey. MTRAC 2. I knew nothing about MTRAC 2 when I started. I had to have a physician as my sponsor, and so I found a physician there. It had to be somebody in Texas, and so he was my sponsor. I registered and started entering all my data in there. And it's an opt-in registry that stores immunization records for children and adults. It's a convenient location. It's free. It doesn't cost anything. It's secure, it's confidential, and available for all Texans. For adults, consent is required once, and it's valid for life unless consent is withdrawn. For children 17 years and younger, parents or legal guardians must sign a minor consent form. When a child turns 18, and signs a consent form, they have lifetime participation. What is not good is if they do not sign a consent form by their 26th birthday, the childhood records are destroyed. So what I've done is I've contacted employees and had one-on-one consultations with them. I set them up with an account, especially all the women that have had babies or the daddies that have had, babies. I bring them in and say, listen, let's sign a consent. Let's look at your child's immunization record. Let's look and see if you're there so that we can get all of this taken care of. Because if you don't, when your son goes to college and he turns 26, his records are gone and they're gone forever. Thank you. I appreciate your time. You have any questions, just let me know, and I appreciate your attentiveness and for coming today.
Works. Any questions? No, doesn't work.
How have you responded to our recent measles outbreak?
How have I responded?
How have you?
Yes, we, from a corporate level, from a corporate level, we created a slide that we, number one, sent to every employee's email address. We have television monitors that they were posted on. And then we have something called Viva Engage, which is a site for all employees to, what you do is when something gets posted for your site, you get notification that something's been posted. And so I've had people come and check to see if their MMRs are current. And of course, if they're, born 1957, like me, I have lifetime, and of course I had the measles several times, different kinds. But we are promoting healthy living, and also we're promoting vaccinations for children. I'll just share with you, I kind of cheated. I have 2 great-grandbabies, and so I wanted to see if the system worked, because healthcare providers are required to put their immunizations in the system. They were both there.
We've also, I think, had a good response. Claudine, you had mentioned people come, okay, I'm sorry, guys. People coming in to follow up, to check on their immunization status. And also the, yeah, I'm just gonna talk up here. And I lost my shoe, okay. I'm a mess. So people checking their immunization status, coming to the nurse to do that. Also, something I meant to mention was that in the IIS, they often will have titers as well. So it's really great. So you can look for those MMR doses, but you can also look for the measles, mumps, and rubella titers might be noted there. So not everyone wants a vaccine. So if you can show them they have good immunity, for our execs, we check MMR titers, and then for people traveling, right now, we also check measles titers for them. We haven't had any cases, thank goodness, because Austin's not really near the larger outbreak in Texas, but we have sites in Kentucky and other places, and it's been spreading. So we wanted to get the information up so everybody could see it. Do you want to say Albertsons?
I'm not directly involved with that, so I am unaware of what's going on in Texas with respect to Albertsons, but there is the Trusted Voice program, so I'm going to guess that if there's any issues, that probably is an outreach mechanism.
Karen, you mentioned that with Cordy, I'm assuming you're using Cordy there too, that they had the ability to push and not pull, and they're working on, trying to, correct that. How has that experience been? Are you satisfied with it? Is it getting there? I realize your words have to be careful.
Well, it's getting there. I mean, if you think about Cordy is there for a different purpose, right? It wasn't designed for that purpose. So I think they're now offering the push mechanism as part of their package. So if anyone does have Cordy, so it will be part of a package, and I think it's just a matter of being a guinea pig for someone to do the poll, and then it'll probably be part of the package then too. But it's just a process, and it's also, people are self-hosted or hosted by Cordy, and so there's a lot of different pieces there too in terms of how many IT support hours that your company has versus what you're doing internally. So I think if you have all the time and all the money in the world, you could get it set up pretty quickly, but it's just a process in order to have it prioritized and have all the other important work you have to do. So for instance, we had to update our Cordy version, and then we had to add on My Cordy edition, and so before we could even get to the state immunization registry project, there were like 2 or 3 major priorities beforehand. So I don't think it's necessarily Cordy, it's also us having the capacity to work with Cordy. So, any other questions? Oh, yeah.
So, Clydeen, thank you for sharing how with the M-Track at age 26, the adults need to register, because I had not heard of that before. And I was wondering, do you also experience the same thing in Minnesota? Because I'm now in the Massachusetts area, and so I'm just wondering, is that nationwide, that age?
Texas is the only one, because Texas is unique. So the Lone Star state. So I'm hoping it's the only Lone Star IIS, but I don't know, and that's why it's really important to check. Minnesota, South Carolina, Wisconsin, I'm not aware of any age cutoff, but those are the 3 I know the best. And when we discovered this for Texas, it just went, oh, this is interesting. You always have to keep an eye on what your registry wants you to do. And also they have a sign where we have an opt-in for adults, so they're just in. Unless you go and you take yourself out. So every state will be different for that too, on whether it's an opt-in or opt-out. And they might define healthcare provider differently too. So we've had that verified and run by our legal and by the registry, but it's always important to check that as well. I mean, to me, if you're a licensed nurse or a licensed physician or PA or NP, you're a healthcare provider, but you got to make sure your law agrees with you when it comes to the data sharing for immunizations. Anything else? Thank you, everybody, and thanks to Beth for being our supporting person on the grant, and Isabel and Julie for being amazing.